So you definitely know the feeling. You're sitting in a clinical room, shivering a little in one of those drafty paper gowns,
Oh, yeah, those terrible gowns.
right? And someone hands you a clipboard with a pen attached by a string. It's time for your procedure, and there's a form you have to sign.
And usually there's this expectation of it just being, an administrative hurdle.
Exactly. You sign the paper, the doctor does the thing, and you go home. It feels exactly like signing the terms and conditions on a new software update.
I mean, you don't read it. You just scroll to the bottom, click accept, and hope for the best.
You really do. We treat it like just one more piece of annoying paperwork standing between us and feeling better.
It feels incredibly routine.
But what if I told you that routine clipboard is actually a massive legal fault line? Like one forged by historic atrocities, Supreme Court battles, and the fundamental question of who actually owns your body.
It is a lot heavier than most people realize.
It really is. Today, we are taking a deep dive into a stack of sources covering medical law, nursing ethics, and the often misunderstood concept of informed consent.
Which is a huge topic.
Massive. And our mission today is to demystify what that ubiquitous hospital form actually means, dissect the shocking events that created our modern rules, and definitively clarify the exact legal role of a nurse in this entire process.
Right.
Okay, let's unpack this. Because making the leap from a quick signature in a drafty room to a heavy legal framework is huge. The sources we're looking at make one thing abundantly clear right away, which is that informed consent is not a piece of paper.
Far from it. The piece of paper is merely the artifact, the receipt, essentially, proving that a highly specific, legally mandated conversation took place.
The receipt.
Exactly. Informed consent itself is an ongoing process, and looking through the legal frameworks in our sources, that process has to contain 5 distinct elements before that pen ever touches the paper.
Okay, what are the 5?
So they are disclosure, comprehension, voluntariness, capacity, and an explicit decision.
I was actually looking at that list in the sources, and a couple of those elements seem a bit, redundant on the surface, like capacity and comprehension. If I am awake, alert, and listening to a surgeon talk, don't I automatically have both?
Well, not necessarily, and that distinction is actually where lawsuits are born.
Really? How so?
So you might have the cognitive capacity to understand language and logic, but if the surgeon explains a complex neurosurgery using only dense medical
Like
jargon,
you have no idea what they're saying.
right, you lack comprehension, you didn't actually understand what was going to happen to you. Conversely, someone could explain a simple blood draw perfectly clearly, ensuring comprehension.
Okay.
But if the patient is severely intoxicated or suffering from acute delirium, they lack the legal capacity to weigh that information.
That makes sense. And then there's voluntariness, which implies you aren't being coerced.
Exactly.
But honestly, the trickiest part of this entire 5-step mechanism seems to be the very first one, disclosure. Because how much information is enough?
That is the million-dollar question.
Right. If a surgeon lists every single microscopic thing that could possibly go wrong, you'd be sitting there for 3 days and you'd be too terrified to get, a hangnail removed.
Oh, absolutely. Finding that line is the most contested part of medical law. For a long time, American courts relied on something called the reasonable physician standard.
Okay, what did that mean in practice?
This meant a doctor only had to disclose the information that a reasonable, similarly trained physician would customarily disclose in that exact same situation.
I have to say, looking at the legal history, that standard seems incredibly flawed.
Oh, it was heavily criticized.
I mean, it is essentially letting a guild of magicians legally decide how much of a trick they have to reveal to the audience. It meant doctors could completely justify keeping patients in the dark about major life-altering risks, just as long as their peers were also keeping their patients in the dark.
Right. The medical profession was entirely defining its own duty to inform. It was a closed loop, and it incentivized a culture of silence. But that closed loop was completely shattered in 1972 with a landmark case called Canterbury v. Spence.
Oh, this is the back surgery case, right?
Yes. Jerry Canterbury was a young man who had back surgery for a herniated disc. His surgeon did not tell him that the procedure carried roughly a 1% risk of paralysis.
Because under that old standard, other doctors wouldn't have bothered mentioning a mere 1% risk either.
Precisely. They would have considered it too small to worry the patient about. But during his recovery in the hospital, Canterbury fell from his bed and did, in fact, become paralyzed.
Oh, it's awful.
It is. And when this went to court, the ruling caused a massive paradigm shift in American medicine. The court determined that failing to disclose even a low-probability, high-severity risk that a patient would want to know about is, in itself, an injury.
That is a fascinating mechanism. So the doctor doesn't even have to perform the surgery badly.
Right.
The surgery could be technically flawless, but simply withholding the information is the actionable offense.
Because it robs the patient of their agency. This case replaced that old closed-loop rule with the reasonable patient standard.
Meaning what, exactly?
Meaning, doctors must disclose whatever a reasonable patient would need to know to make an informed decision, completely regardless of what other doctors typically say at the bedside.
That's a huge shift.
It really was. Now, a minority of U.S. states still use the old physician-centered standard, but Canterbury v. Spence shifted the fundamental center of gravity in medical law from professional custom to patient autonomy.
Which raises a really important question. If the patient's right to know, this sacred idea of bodily autonomy, is the new center of the legal universe, where did that idea actually come from?
Well, it certainly didn't appear overnight.
Because reading through the historical sources, it wasn't always this way.
No, not at all. We can trace the legal seed back to 1914 to a case called Schloendorff v. Society of New York Hospital.
Right.
A patient consented to an abdominal exam under anesthesia but explicitly refused surgery. While she was under, the surgeon removed a tumor anyway.
And that case gives us the quote that nursing and medical students still memorize to this day, from Justice Benjamin Cardozo. See, it's every human being of adult years and sound mind has a right to determine what shall be done with his own body.
Which is a beautiful foundational statement, though it is worth noting a fascinating legal quirk here.
Oh, yeah.
That famous quote was actually just dicta.
Meaning it was just a side comment in the judge's written opinion, right?
Yeah.
It wasn't the actual legally binding rule of the case.
Correct. The case itself was actually decided on the technicalities of hospital immunity. Cardozo was just sort of philosophizing on the nature of human rights.
Wow, so a side note became the absolute bedrock of bodily autonomy.
It did. Interestingly, the actual compound term informed consent wasn't even coined until decades later. In a 1957 California case called Salgo, where a patient woke up permanently paralyzed after a procedure because he hadn't been warned of the risk.
So the legal framework was slowly building in the courtrooms. But the ethical scaffolding, the deep moral reason we treat this as a human right today, didn't come from judges debating back surgeries.
No.
Our sources make it painfully clear that modern medical ethics were forged in the fire of some truly horrific atrocities.
If we connect this to the bigger picture, the evolution of these ethical mechanisms was entirely reactive.
Reactive to what?
Well, following World War II, the Nuremberg trials exposed the lethal, forced experiments conducted by Nazi physicians on concentration camp prisoners.
Right.
The resulting 1947 Nuremberg Code is widely considered the founding document of modern informed consent. It states right in its first line that voluntary consent of the human subject is absolutely essential.
But the sources also point out that the U.S. didn't just learn this lesson from looking overseas. We had our own domestic scandals that forced this doctrine into everyday practice.
We did, unfortunately.
The most infamous, of course, being the Tuskegee syphilis study.
Yes. A study spanning an unbelievable 40 years. From 1932 all the way to 1972, the U.S. Public Health Service enrolled nearly 400 black men in Alabama who had syphilis, but researchers deliberately never told them they had the disease.
They were just told they were being treated for bad blood.
Exactly.
And the most damning detail in the historical record is that the researchers intentionally withheld treatment for 25 years after penicillin became the standard, widely available cure.
It's horrifying.
They just wanted to observe the natural, fatal progression of the disease. They didn't stop until a whistleblower leaked the reality of the study to the press in 1972.
And Tuskegee wasn't an isolated mindset of the era. The sources detailed the Cold War human radiation experiments where the government exposed thousands of people, including pregnant women and terminally ill patients, to radiation without proper disclosure, all for defense research.
That is just wow.
And then there were the Willowbrook hepatitis studies.
The Willowbrook case is chilling because of how it manipulated that element of voluntariness we talked about earlier. Researchers deliberately infected intellectually disabled children with hepatitis.
Yes.
To get the parents to consent, they sometimes made admission to this highly sought-after, overcrowded state facility conditional on participating in the study.
That is the ultimate example of coercion.
Yeah.
When a vulnerable population is denied basic care or access unless they submit to experimentation, Consent cannot possibly be voluntary.
Definitely not.
These public outrages finally forced the government's hand. It led to the 1979 Belmont Report.
And the Belmont Report isn't just a list of rules. Looking at how it's structured, it's essentially a mathematical balancing act designed to prevent these specific abuses.
Very much so.
It codified 3 bioethical principles: respect for persons, which translates to autonomy; beneficence, which means acting in the patient's best interest; and justice.
The report acknowledged that these principles will often conflict. You have to balance a patient's autonomy against the doctor's duty of beneficence. But autonomy emerged as the heavyweight champion of that trio. Your body is yours.
But if autonomy is this absolute ironclad rule, what happens when a piece of your body is removed and sitting in a jar across the room?
Oh, this is where it gets complicated.
Is it still yours? Can someone else profit off a piece of you?
This brings us to a very bizarre legal gray area regarding excised tissue. Let's look at the foundational case of Henrietta Lacks from 1951.
She was a Black woman treated for cervical cancer at Johns Hopkins, right?
Yes. Her cells were taken without her knowledge or consent, which, horrifyingly, was a standard legal practice at the time.
Just standard procedure.
Yeah. Those cells became known as HeLa cells, and they were the first human cells to reproduce indefinitely in a lab.
Incredible.
They literally changed the trajectory of human history. They were the foundation for the polio vaccine, cancer treatments, and countless other breakthroughs.
But her family remained completely in the dark, living in poverty while her cells were sold and studied worldwide for decades.
Exactly. Her specific case eventually forced massive changes to the laws governing research consent, specifically the 2018 revision of the Common Rule.
All right.
But the question of who actually owns the physical tissue gets even weirder when you look at the 1990 case of Moore v. Regents of the University of California.
Okay, let's get into this one.
So John Moore had his spleen removed as part of his leukemia treatment. Without telling him, his surgeon patented a cell line derived from Moore's unique tissue, the Mo cell line, which became massively commercially valuable.
Wait, I need to walk through the logic of this ruling. The doctor gets in trouble for not disclosing his financial interest? Right. But Moore still doesn't get a cut of the millions of dollars in profits from his own spleen. How does that work?
It seems entirely counterintuitive, I know. But the court drew a very fine legal line here. They ruled that the doctor did breach his fiduciary duty.
Meaning he violated that sacred legal trust where a doctor is obligated to act solely in the patient's best physical and financial interest rather than their own.
Exactly. Hiding his financial interest was a breach of that duty, and it was a breach of informed consent. That was actionable. Moore could sue the doctor for that deception.
Okay.
However, the court also ruled that patients have no property rights over their excised cells once they are removed from the body.
That's wild.
The court's reasoning was that granting property rights to patients over every removed appendix or blood sample would severely chill biological research and stifle medical innovation.
So the doctor is punished for the secret, but the patient still doesn't own the biological material once it hits the petri dish.
Exactly.
Because Moore proves that you lose ownership once the tissue leaves your body. That conversation at the bedside before the scalpel hits the skin is literally your last line of defense.
This absolutely is.
Which puts an unbelievable amount of pressure on the person holding the clipboard. And usually, that person is a nurse. Here's where it gets really interesting.
It does. This brings us to the single biggest misconception we need to debunk for anyone working in or interacting with the healthcare system.
Let's hear it.
The nurse who gets the patient's signature is not legally responsible for obtaining the informed consent.
Let me repeat that because it is the most vital takeaway in our nursing sources. The nurse holding the clipboard is not the one liable for the disclosure.
Not at all.
Wow.
The legal duty to disclose the risks, the benefits, and the alternatives belongs entirely and exclusively to the provider who is actually performing the procedure.
So the surgeon.
The physician, the surgeon, the advanced practice provider, meaning a nurse practitioner or PA who is doing the actual intervention, they hold the duty to inform.
So what is the frontline nurse's actual role in that high-stakes moment? Because they're the ones standing there with the paper.
The nurse's legal role is to witness the patient's signature, to confirm that the patient appears to be acting voluntarily, and, crucially, to act as a patient advocate.
Advocate.
Right. Let's walk through a real scenario. If a nurse hands you the form and you say, wait, what are the alternatives to this surgery? The doctor didn't mention any. The nurse's job is to stop the line.
They don't try to explain the surgical alternatives themselves to save time?
Never. because doing so would mean the nurse is absorbing the physician's liability. They escalate the issue back to the provider. The nurse says, "I cannot witness the signature until the surgeon comes back and answers your questions."
That distinction changes everything. It transforms the clipboard moment from, I, the nurse, am legally certifying that you understand complex anatomy, to, I am witnessing that you are signing this willingly and I will fiercely advocate for you if you look confused.
Exactly.
And the sources outline some really vital legal distinctions that frontline workers have to navigate regarding this, like the difference between battery and negligence in tort law.
Right, tort law being the area of law that deals with civil wrongs and damages. And the distinction here is massive.
How so?
If a provider performs a procedure with absolutely no consent at all, say amputating the wrong leg, or operating on a patient who explicitly refused, that is battery. It is unauthorized touching.
Okay, that makes sense.
But if they perform a procedure and the patient signed the consent form, but the doctor failed to adequately disclose a major risk, like the Canterbury paralysis case, that is negligence.
Negligence, got it.
Yeah.
There's also a major distinction made in the sources between capacity and competence. We touched on capacity earlier, but clinically, these two terms are worlds apart.
They are. The best way to understand this is to think of it like a driver's license.
Okay, I like analogies.
Competence is having your driver's license. It is a global legal status granted by the state, decided by a judge in a court of law. It says you are generally fit to make decisions.
Right.
Capacity, on the other hand, is whether you are sober enough to drive this specific car right now.
Oh, that's really clear.
It is a clinical, situational decision made by a healthcare provider at the bedside.
So you can be a legally competent person, but temporarily lack capacity for one afternoon because you just woke up from anesthesia.
Exactly. And this leads to an obvious question. What happens when you are entirely unconscious? Let's say you're rolled into the ER after a car accident. You can't sign a form. You can't show capacity. Do the doctors just stand around waiting for a lawyer while you bleed out?
I would certainly hope not.
They don't, thanks to the emergency doctrine.
Oh, okay.
It provides implied consent. If an unconscious patient faces imminent, serious harm or death, the law assumes that a reasonable person would consent to life-saving care. The doctors can act immediately without explicit consent.
So understanding this entire framework, battery versus negligence, capacity versus competence, the emergency doctrine, it isn't just about passing a nursing exam or avoiding a lawsuit. It's about navigating the most complex, real-time ethical dilemmas we face in society.
And those dilemmas are constantly evolving. The ultimate live debate in clinical ethics today is the tension between paternalism and autonomy.
Meaning, when, if ever, can doctors override a competent patient's informed refusal of care, claiming it is for their own good?
Exactly. And the sources highlight a very specific paradigmatic test case for this. Jehovah's Witness patients who refuse blood transfusions on religious grounds.
Right. That's a classic ethical dilemma.
It is the ultimate stress test of autonomy, and courts have consistently upheld a competent adult's right to refuse a transfusion, even if it is a 100% medical certainty that the refusal will result in their immediate death.
Wow.
The patient's right to dictate what happens to their own body wins over the doctor's duty to save a life.
And that absolute right to refuse was codified on a national level in the 1990 case, Fuzan v. Director.
Yes, that was the Supreme Court's first major right-to-die case. It affirmed that competent patients have a constitutionally protected liberty interest in refusing unwanted medical treatment, including life-sustaining treatment like feeding tubes.
And that single case is the entire reason we have modern advance directives and living wills today.
It is.
It's fascinating how this tension between individual autonomy and public health beneficence plays out everywhere. We saw it heavily debated with modern vaccine mandates. And regardless of where anyone stands politically on those mandates, you can see the exact same ethical fault lines from our deep dive.
You really can.
Do we prioritize the individual's absolute right to refuse a medical intervention? Or do we prioritize the broader public health need to stop a communicable disease? It's the same fundamental legal struggle.
The ethical framework is tested by every new societal crisis.
And a key point the sources make is about revocability. Consent is never logged in. You can withdraw your consent mid-procedure, assuming it's clinically safe to stop.
Right.
And if a surgeon is inside you and finds something totally unexpected, some new material finding, they generally need to wake you up and get new consent to treat it. They can't just say, well, I was already in there, so I fixed it.
No, they cannot. This raises an important question as we look to the future. These laws were built over a century for surgeons, scalpels, and physical procedures. They are severely struggling to keep up with tomorrow's technology.
Like what?
Think about genetic testing companies asking you to consent to sharing your DNA data. Do you really comprehend what you are consenting to 20 years from now when that data can be used in ways we haven't even invented yet?
Or the looming debate over artificial intelligence. Hospitals are struggling right now to figure out if they need to explicitly disclose to patients that an AI diagnostic tool was used to read their scans.
Exactly.
Is that part of the reasonable patient standard? Does a patient need to know a computer made the call, not a human?
It is the bleeding edge of medical law. The foundational rules, autonomy, disclosure, comprehension are the exact same, but the application is entirely uncharted territory.
So what does this all mean for you, the listener? We've traveled from the incredibly dark history of forced experiments that birthed the very idea of bodily autonomy to the realization that informed consent is not a piece of paper, but a continuous, living conversation.
Yes.
We've seen the legal loopholes of tissue ownership, and we've clarified the vital, fiercely protective role of the nurse who acts as your advocate when that final signature is requested.
The main takeaway is that your bodily autonomy was incredibly hard won by those who came before you, and it is entirely yours to exercise and protect.
But as we look to that uncharted future, I want to leave you with a final provocative thought to mull over. We mentioned AI just a second ago. Imagine a hospital starts using a highly advanced AI to diagnose your illness or recommend a surgery.
Okay.
That AI was trained on millions of past patients' data, finding patterns no human doctor could ever see. If even the software developers who built the AI admit that the algorithm is a black box, meaning they don't actually fully understand how it reaches its conclusions.
How can a doctor ever provide you with truly informed consent?
Exactly. Can you, or anyone, legally consent to a medical decision that no human mind fully comprehends? Next time you're sitting on that exam table in that drafty gown and someone hands you a clipboard, take a second to think about the massive invisible machinery behind that single piece of paper. This has been another deep dive into the forces shaping our world. Thank you for listening, and keep questioning the world around you.